Welcome back to this introduction lecture on pain. This one is facial pain part 2. If we look at the diagnosis of neuropathic orofacial pain and make a brief classification, neuropathic orofacial may be described as neuralgias such as trigeminal neuralgia, glossopharyngeal neuralgia, dysesthesia, under which burning mouth syndrome comes in, and those neuropathies caused by trauma. In this classification, I have added in TMD under that in dotted line because many believe that there is a central component to temperamental disorders, and it's important to understand that part of it. So peripheral neuropathy can involve trauma or neuritis, neuralgias, trigeminal neuralgia, which may have a combined peripheral and central component, and those with the central component such as multiple sclerosis, anesthesia dolorosa, persistent idiopathic pain or PDAP, burning mouth syndrome or dysesthesia also can have a combined components. Neuropathic pain is pain caused by a nerve injury or disease, or as well as by involvement of nerves in other disease processes. Rafael Benaliel et al. Coined the term neuropathic orofacial pain to describe neuropathic pain of maxillofacial origin. And neuropathic pain often is described as shooting, burning, tingling, or numbness. Quite often will be controlled well with antidepressants or anticonvulsants. Conditions such as neuralgia, burning mouth syndrome, and PAFP are in this category. TMD also has a neuropathic component, but is poorly controlled by majority of our common pain medications or antidepressants and anticonvulsants. If we look at trigeminal neuralgia, it's a sudden onset, usually unilateral, severe, brief, stabbing, recurrent episodes of pain in the distribution of one or more of the branches of trigeminal nerve. So you need to get a good pain history to be able to diagnose this, and imaging is required to exclude the possibility of a tumor or vascular compression or plaques, such as in multiple sclerosis, causing the problem. And it is good to record the character duration. Usually it's short duration, and the pain severity is described often as 11 out of 10, and patients often can be suicidal. Exacerbating factors could be brushing the teeth or wind, hitting the face or shaving or light touch. Burning mouth syndrome is characterized by burning sensation or other dysesthesia of the oral mucosa, and there's usually no clinical or abnormal clinical or laboratory findings. And pain is described usually as burning with variable intensity. It's usually continuous and may be associated with dysesthesia, xerostomia, or thirst and psychological problems. Persistent dentoalveolar pain was previously known as atypical dentalgia, phantom tooth pain, or neuropathic tooth pain, and this problem is usually persistent pain localized into the dentoalveolar region with no obvious pathology associated with it. We now turn to management. So management of chronic pain in general involves the improvement of the psychological component that may be involved, and mindfulness-based stress reduction has been shown to improve reduction in pain when compared to those people the control group. And this shows that there is an interaction between sensory, cognitive, and affective processes. And functional MRIs were used to validate this study. Reduction in catastrophizing. Catastrophizing was previously associated with increased pain severity, emotional distress, and disability in chronic pain patients. And it's also a contributing factor in the development of neuropathic pain. We know that through studies, gender and catastrophizing, women tend to catastrophize more. Positive emotions and catastrophizing indicated that positive attitudes reduce catastrophizing scale. So blowing things out of proportion or making a mountain out of a molehill will not help your cause in trying to manage pain. So it's better to have a positive attitude. We know that exercise can improve mood, may be enjoyable, it boosts energy, and therefore can enhance our ability to manage pain. We know that sleep is important. Lack of sleep can interfere with our ability to manage pain and increase the pain levels. So giving some simple information to the patient may help with our management process. We also know that Doral et al. Showed that negative cognition and emotional response to pain will amplify the pain, and they also showed that love affects the rewarding pathways and has an actual physiological improvement in the pain. So if we talk about management, TMD, at this stage we talk about conservative advice and self-help exercises. Cognitive behaviour therapy forms part of that. Intraoral appliance therapy, physiotherapy, pharmacotherapy, occasionally arthrocentesis, and in less than 3% of the cases where there is joint pathology, then surgery may be involved. So the intraoral appliance basically involves a flat acrylic plane appliance that there's evidence now to show that there is effectiveness of TMD management with these kinds of appliances, and some thoughts are that there may be some neuromodulation going on with the use of these appliances. Others believe that it may be a placebo effect. Pharmacotherapy, muscle relaxants can be used occasionally for a short-term improvement. Paracetamol as required. Some of the other stronger pain relief usually is assessed on a case-by-case basis, but there's no evidence that current drug therapy is providing a real benefit long-term. Counselling and cognitive behaviour therapy has been shown to be effective, but you need to make sure you look for comorbidities or other pain problems coexisting as well. Arthrocentesis involves insertion of needle into the upper joint compartment and flushing it out. The suggestion is that this will get rid of any adhesions and or any inflammatory mediators that are within the joint compartment, and that may be effective in very small number of cases where the joint pain is associated with some localized changes. Joint surgery, replacement of the TM joint may be required in those cases where there is pathology that has caused destruction, including tumours and arthritic conditions. And the cultural differences do occur in this. When I visited this church when I was at an overseas conference, we went into one of the rooms where the local belief was that if you took a part of the body that's ailing and hung it up on the roof, then that would create an improvement in the pain. So obviously some of these people have got pain in the hands, some obviously have got pain in the head. These cultural beliefs may have an impact, and that may be the psychological impact it has on those patients, and that might actually have a positive effect physiologically as well. So management of neuropathic pain, coming back to burning mouth syndrome, Patton et al. Published an article which talked about the fact that burning mouth can be caused by many things, and you need to do your proper exam and special tests to exclude some of these problems. They could be nutritional deficiencies or medication related, and once those have been excluded, then your diagnosis of burning mouth syndrome can be used. And some of the things that can be used for the management of burning mouth syndrome: topical capsaicin, lidocaine, doxepin, sometimes systemically tricyclic antidepressants, especially nortriptyline, clonazepam, but clonazepam also can be used topically in these cases. The evidence is still lacking, but clinical practice does indicate that some of these methods of management is quite effective in these patients. Trigeminal neuralgia, carbamazepine is quite effective and diagnostic for the condition. Gabapentin and pregabalin are also anticonvulsants that have less systemic side effects but are quite effective. Procedural in those cases where there's vascular compression, microvascular decompression can be quite effective. Rhizotomy, either probably the radio frequency where you're not actually using a physical way of either cutting the nerve or interfering with the nerve would be useful, can be useful in those refractive cases. This is basically like jump-starting the trigeminal nerve. And then on top of that, general management procedures that we have discussed for chronic pain. For PDAP, usually once a diagnosis is made, you can use topical medications, address any comorbid mood and personality disorders where they are present. Tricyclic antidepressants, nortriptyline, can be quite effective as well, but it's usually a combination therapy. So in summary, we know that TMD is continuous pain description, whereas trigeminal neuralgia is paroxysmal. TMD can be uni or bilateral. Trigeminal neuralgia is usually unilateral. Burning-Mount syndrome can be continuous pain with bilateral distribution, and PDAP is usually continuous but unilateral. And the pain levels, you can see that they can vary depending on the condition, and usually there's no nerve deficiency associated. And we do need to talk about imaging for TMD, as well as some of the other pain conditions, and some of them probably should have blood tests, especially with trigeminal neuralgia. A baseline liver function test is required if you're going to be using carbamazepine. Vitamin B12, folate iron levels and zinc levels are important to review, because improvement of that may help with your management, and management can vary depending on the condition. Thank you.